Hi guys, welcome back to the channel. Today we are discussing the CESAR trial, Efficacy and Economic Assessment of Conventional Ventilator Support versus Extracorporeal Membrane Oxygenation for the Severe Adult Respiratory Failure.
Disclaimer: the content and information on this video is for education purpose only and is not intended to be recommendation of any kind of some whatever. Under any circumstances, the author accept no liable for any indirect, incidental, consequential, exemplary damages arises. This video may contain copyright material, the use of which may not have been specifically authorized by copyright owner. This video is available in an effort to advance understanding of educational content.
Clinical question: is the extracorporeal membrane oxygenation ECMO is a safe, efficacious, and cost-effective treatment compared with the conventional ventilation for the management of severe adult respiratory failure? Design for the study: randomized control trial, 1:1 ratio to receive conventional ventilation or refer to the consideration for treatment of ECMO. 25% number 22 of patients randomized to ECMO never received this treatment. 5 patients died either before or during the transfer. The remaining 17 patients continued with the conventional ventilation. Non-blinded to clinician, although researchers were blinded at a 6-month follow-up. Power calculation were based on the antiseptic 70% mortality in a conventional management group, assuming the 10% risk severe disability in the surviving patients in both treatment groups. 120 patients in each group, 240 in total, were required to the detection by 1/4 in the proportion of the patient with achieving the primary outcome from 73 to 55. This power calculation was reviewed in 2003. At this point, 63 patients, 60% were recruited. Lower sample size of 180 patients was selected to detect the reduction by 1:3. Intention to treat analysis. Setting for this study: this is a UK-based study. 92 conventional tertiary ICU and 11 referral hospital, which sent patient to the conventional center if allocated to receive conventional management. Glenfield Hospital Leicester was the only center where ECMO treatment took place in July 2001 to August 2006. Population for this study: inclusion criteria for severe but potential reversible respiratory failure, Murray score of 3 or more based on FI to PR2 ratio, PEEP lung compliance, XA, FI to 1 or uncompensated hypercapnia with pH of less than 7.2 despite optimal conventional ventilation, age 18 to 65. Exclusion criteria: peak inspiratory pressure more than 30 cm water or PR2 FI2 more than 8.8 in our ventilator shows 80% for more than 7 days. Signs of intracranial bleeding, contraindication to hypernization, plan limitation support. 180 patient randomized, 90 receive conventional and 90 receive ECMO. Primary cause of severe respiratory failure was pneumonia in about 2/3 of the patient. Intervention: transfer to ECMO specialist center and consideration for ECMO treatment. All patients randomized for consideration of ECMO were transferred by Glenfield Bone Specialist Retrieval Team. No patient was transferred on ECMO. If patients were hemodynamically stable, standard protocol was used: pressure restricted mechanical ventilation at 30 cm of water, titrate optimal PEEP, FI2 adhesives to maintain saturation 90, diuresis, pressure control ventilation 40%, and prone position. Low volume, low pressure ventilation, 84 patients, 93%. If patient did not respond within 12 hours, they receive cannulation and ECMO according to the published institutional protocols. Non-responder: FI2 more than 0.9 to maintain saturation 90%, respiratory or metabolic acidosis, pH less than 7.2 or was hemodynamically unstable. ECMO was done in venous mode with a percutaneous cannulation. Servo control roller pumps, Sprocket, Fairbrook, Germany, and polymethyl pentane oxygenator. Meadows Medicines, Wolfsburg, Germany, where use was continued until the lung recovery or apparently irreversible multi-organ failure. Control: continue conventional ventilation, pressure control mode with a Siemens servo 300 ventilators, or high frequency oscillatory ventilation, or both. Low volume, low pressure ventilation, 63 patient, 70%. Outcome: primary outcome, death or severe disability, confined to the bed and inability to wash and dress alone at a 6 months after randomization. 63% percent in ECMO versus 47 in conventional ventilation group. RR is not for ECMO but for the referral to single ECMO capable hospital for assessment and management. Death less than 6 months or before the discharge, 57 patients, 63 in ECMO versus 45 patients in conventional, 50% conventional ventilation group. Peace value 0.07. In the ECMO group, 17 of the 85 patients that arrived in Glenfield continued to receive conventional ventilation rather than ECMO. 82 of these patients survived without severe disability. ECMO 57 versus conventional 45 patients. Severe disability 0 versus 1. Data for 3 patients was missing from the conventional ventilation group. Assuming that these patients had all survived but been severely disabled or had been severely disabled, the relative risk of primary outcome will be 0.67. Respectively, in later comparison, the primary endpoint narrowly missed the threshold for the significance. Secondary outcome: ECMO group versus conventional management. Use of high frequency oscillator or jet ventilation, 6 patients versus 13 patients. Prone ventilation, 32 versus 38 patients. Use of steroid, 76 versus 58. Use Mars, 15 versus 0. Nitric oxide or CCBHF, conventional high frequency, no difference. ICU length of stay, 24 versus 13. Hospital length of stay, 35 versus 17. Health status at 6 months. Gain of 0.3 quality adjusted life years. Lifetime model will be predict the cost quality life of index of ECMO to be the in dollar values. 5 patients in ECMO group died in 3 patients died before could be transferred and 2 died in transit. Adverse events reported: mechanical failure of the oxygen supply in the ambulance resulting in a 1 day vessel perforation during the cannulation, which was felt to contribute the death of the patient. Catastrophic pulmonary hemorrhage during the transfer, which was felt to be cause of the underlying disease. Strength for this study: early assignment to the treatment groups, incorporation of transport tricks into the trial design, robust economic analysis, 6-month follow-up testing was done in patient home by trained researchers who were blinded to treatment allocation. Patients and their relatives were instructed to not reveal which treatment had been used. Scarf was used to cover the neck to mask cannulation status. Weaknesses: the study was more about treatment in single specialist center with a potential for ECMO treatment versus standard based UK treatment rather than ECMO versus conventional. Only 76% in the ECMO group actually received ECMO. Perhaps it would be how better if patients were randomized at the point where arrived at Glenfield. Pragmatic decision not to do so is understandable. Lack of management protocol for patient randomized in conventional ventilation. 93% in intervention group versus 70 in control group were treated with the lung protective ventilation. Health evaluation data representation confusing. First glance: 33 patients in ECMO. ECMO reported no problem with mobility versus 21 patients in conventional group. However, data is misleading. The ECMO group would be 53 in ARE. 5% looks less impressive than 12%, particularly when up to 25% patients in ECMO group never received this treatment. Intention to treat analysis useful only where the minimal data lost up to follow. Full follow-up information was only available in 58 versus in 36 of patients in the ECMO group as conventional group respectively. Author conclusion recommendation transferring the adult patient with a severe but potentially reversible respiratory failure whose Murray score more than 3 or who have pH less than 7.2 and optimum conventional management to center where ECMO based management is available. Bottom line for this study, the CESAR study supports the ECMO as a valid treatment option for the management of patients with a severe respiratory failure. However, it does not show the ECMO is better than conventional ventilation with incomplete follow-up data. In nearly half of the patients, 25% of the patient ECMO group not actually receiving ECMO, we are left with insufficient evidence as to whether the ECMO is better or worse than protocolized ADS-net ventilation in adult patients with severe respiratory failure. This study does not highlight the importance of involving specialists in its effective lung protective ventilation, ECMO as an option in refractory respiratory failure.